everybody, for Katrina is one of our specialist nurses for the pain team. She's got over 25 years of experience in this particular field. She is a brilliant specialist nurse with a lot of knowledge, can manage patients brilliantly. She's part of our MDT for the pain management, and I've learned a lot from her. Her slide and her presentation is, as the name suggests, and I hope you will benefit from this. Over to you, Katrina.
Can you hear me?
Loud and clear.
And can you see the slides? I'm just trying to see if I can
Yes.
make them bigger.
No, I think we're fine. Yeah.
I think, yeah. Thank you. I've jumped into Farah Nadeem, my clinical psychologist's colleague's place. She can't be with us unfortunately this morning, so I've jumped into her place. But thank you for the opportunity just to talk about the sheer impact of endometriosis on these poor ladies. Good to work with you as an MDT, and I sit in chronic pain clinic. I have done for many years, and I will see the ladies coming from yourselves, from GPs who are awaiting treatment, going through management, coming back into gynae team for recurrence of their symptoms. Some have already had the diagnosis, some are still waiting investigations, so they are still in that complexity of what's going on. So I just really wanted just to start with Farah's slide, just talking about psychology being mind and behavior, how we think and feel and believe what's going on will affect these ladies, what they are doing. And as pain goes on, their fear, their anxiety, they will keep searching. So they will keep presenting to us, and I guess yourselves as well. And it's very much with this long journey, of finding out what it is, and what is it? We're not meant to have pain. Is it anything sinister? So it drives the search for them. Health psychology suggests we, as human beings, are complex systems and shouldn't be viewed as a single causal factor. This is why in chronic pain management, for many decades now, we see people and use the biopsychosocial approach, which my colleague Madden has highlighted, intrinsically linked, the two of them, our psychological state and our physical pain perception. So, and very complex and very subjective. Endometriosis associated with chronic pain, which I won't go into again, and we can hopefully carry on with the video over lunch from my colleague Madden. There's a wealth of research into psychology of pain across many conditions, but actually there's been probably a lack of focus on endometriosis, and then there needs to be more to flag up the impact of this on these women, and also just to raise the fact that these women might be coming in already with mental health illness. So they may already have other long-term conditions, but they may already be haven't got the resilience to cope when endometriosis comes along, pelvic pain comes along, because they already maybe have a background of depression, trauma. And we are in a mental health crisis at the minute with lack of resources. So they won't come with the support they probably need to cope with their mental health as well as endometriosis and all that brings. And lastly, just on this slide, psychology influences how we perceive pain. And my colleague Madden has already highlighted this. In that anxiety, how we think and feel about all this pain is like a volume switch on the pain perception. We know this from research, from the ascending pathways, This is not just with chronic pain, it's with all pain conditions. So again, flagging up if they already have anxiety, chronic pain, pelvic pain comes along, they are not best placed to manage this. They don't fare as well. We know chronic pain is a long-term condition in its own right, depression as well. So we know when people are coping with more than 2 long-term conditions, they don't fare as well. We know this on the back of the long-term conditions national service frameworks, and it's all pointing towards biopsychosocial approach and self-management. We could, I mean, I've got 10 minutes, but we could spend a whole day looking at the psychological impact on these ladies. I see ladies in chronic pain clinic who already probably know they can't have babies, and that in itself, I have go through many boxes of tissues because they are still coming to terms with they can't be a mum, and the grief around that. Some may have had kids before, but some have never had that, and they are still going through that grief process when they come to us, and that is huge. So these ladies are coping with many different factors coming in when they see yourselves and us, grief, anger around it, coming to terms, hopes squashed, and so they're coming to us, with the pain, the impact on their life, the disease itself, and the infertility on top of this. I say I could spend a whole day talking about these ladies and the impact on them, bless them. Quality of life. Honestly, it's a patient often once said to me, it's like dropping a pebble into water. It will impact every aspect of their lives. For us, when they're coming to us in chronic pain clinic, they talk about the anxiety of finding a diagnosis, and that there is that long journey, exhausting journey of trying to find a solution. And patients tell me that their life's on hold. Their life's on hold until they can find a solution. Investigations have been completed, and it's this fear of the pain being something sinister. And what if investigations aren't conclusive? Has something been missed? So if investigations aren't conclusive, we in clinic have they have to navigate through. Well, all what we can do is say what it isn't, and they are still on this search, and it's agonizing. You can see the struggle in them. Along with this, depression, isolation. That's why we have our pain programs to help people know that they're not alone in all this. Anger and frustration I've mentioned, and the fact that pain is invisible. Huge impact this is, because they're continually having to justify to people why they can and can't do things, to family, loved ones, colleagues, and it's the fact that pain waxes and wanes. They'll have a better day, they can do a little bit more, but it comes at a cost, and they will have days in bed. So I see ladies that I spend days in bed, and in fact their confidence and self-esteem has gone down, their self-care, and they're on a downward spiral, and they just want to be justified and not feel judged about this. So Madden's already mentioned about some of the measures, the psychological measures that we are using: CBT, mindfulness. ACT is a third wave CBT, and it's being used more and more, ACT, within chronic pain conditions across the board, all chronic pain conditions. And it's around adjustment, it's around acceptance, because if pain's not going, how are they going to live alongside the pain? and it's all very much based around value-based goals. In all of this traumatic journey, in all of this, what do they want to keep hold of? What's important to them? And to them, it's normally that I want to be a good, daughter for some, mother. Of course, that's dashed for some of them. What hits their heart? What's important to them in all of this that they can keep doing for quality of life despite pain? Because sadly, when they come to us, we're not looking at curative here. We're looking at pain's ongoing. And because of the changes that have been happening in the central nervous system, the central sensitization, which we've touched on today, we're probably not looking at pain going. And to have that conversation with patients, the fact that despite, measures, drugs, surgery, all of that, they're probably going to be having to live with some degree of pain. That's never a conversation I, after all these years, like to have, and I think it's them just coming to terms with that, and that we know, talking to my psychologists I've worked with, that just takes time, and it can take a few years for them to adjust to acceptance that probably pain is there's going to be some degree of pain, and it's a bit like a grief process. It can take quite a few years, bless them. And just so lastly, their well-being, hugely connected. Her sense of well-being, what she can do, and we spend a lot of time, which my colleague Madden has touched on, in self-management, on the back of long-term conditions, NICE guidelines. Self-management is huge and very much supported by NHS England for all long-term conditions, and pain is one of them. So we very much look at not just quality of life, their self-care, because often that has drifted. Our understanding around the role of this is incredibly important. But in all of this, they just want to feel believed and validated in all this, and shed loads of compassion and shed loads of listening. Our patients walk out of here often still in pain, but they have told us, I felt listened to, believed, that this isn't in my head, and validated, and that there's still some things that we can do to give them hope and to build on quality of life and to get things back into their lives, get things back on the calendars, in the diaries, so that they don't feel life's on hold and life has stopped, that they can build things back into their life despite pain. So, and I would invite anybody to come to Pain Clinic and sit in our clinics, and how we help navigate these ladies' lives living with endometriosis. So thank you. I could talk all day on this.
No, thank you, Katrina. Really appreciate your input, and yes, I think you're absolutely right. Bottom line is we need to prepare patients to live with the pain, and it needs to be a multidisciplinary approach. And I really thank you for stepping in. Really appreciate it.
Are there any questions at all anybody wishes to ask? Or
it really reflects what we see. Thank you very much, Katrina. Very interesting talk, and it really reflects what we see and gives us some more insight into what we see and how these patients feel, because we need to learn from you, because a lot of the problems we see is the how they take the problem and the frustration. There a great deal of frustration amongst these young women.
Yeah.
Not knowing the cause and not getting to the bottom of it. So thank you very much.
You're welcome.
Thank you. Any questions, ladies, gentlemen? If there are no questions, then we can.
Katrina, just a quick one. Which patients actually do you take? From where do you take referrals from? Is it mainly just the endometriosis service, or are people in primary or secondary care able to refer you patients?
Both. Both.
Both in the NHS and privately?
Yes, we have had people referred through from private, but a good number from GP primary care, but from yourselves. In fact, most of our ladies with endometriosis are from your good selves, and many are still on your caseload. So we have a number of patients we are sharing at the same time.
Yes.
So good to talk to them. Good to collaborate and be keen to do more MDTs just to navigate sort of what's best for these patients.
Out of the patients you see, what proportion do you think you refer for psychological support, Saad?
All of them.
It's part and unfortunately, I mean, I don't know, fortunately or unfortunately, it's part and parcel of the pain management, psychological assessment, self-assessment of pain, self-management of pain. Katrina, please, I mean, tell me if there is anything else. But I mean, this is what I have learned sitting in with you and the pain team. Yes, because these women, by the time they come to the pain team, we have already exhausted all forms of hormonal and surgical modalities, or they're fertility patients, and we cannot give them a more radical treatment. Am I right there, Prof?
Unfortunately, a lot of women need to be referred, but we know how long the waiting time is.
Yes.
We have obviously developed a good relationship with our pain team and psychiatrists and specialist nurse. And I mean, inevitably, we do some of this counseling, and one of the most effective ways, from our perspective, is listening to the patients. If they feel that they are being listened to,
yes,
and their feelings and their symptoms are appreciated, and that they find someone who believes that they do have, because this is the most frustrating thing for them. And I've heard this so many times that I have eventually at last found some people to listen to, some professionals to listen to them. But obviously the question I can ask is, how can we get more referrals without long wait, a year and a half or 2 years? That's the main obviously challenge that we're having.
Is that the waiting time for the psychological support?
Yes, unfortunately.
Okay. Ahmed Al-Nagar, you have a question?
For my colleague from the gynecologist, has anyone experienced prescribing neuromodulator medication like gabapentin or pregabalin themselves, or we just get this task to be delegated to the pain management team? Because sometimes we use like amitriptyline for interstitial cystitis. We prescribe it for the patient ourselves. Also for vulvodynia, sometimes we could prescribe. But has anyone have this experience to prescribe the pregabalin or gabapentin themselves, or we usually refer them to the pain management here just to get this prescribed for them?
I've had this one episode where I essentially, again, because of the waiting list, so I emailed Katrina yourself with the full history of the patient. And then obviously you asked the relevant questions. And then, yes, we were able to start, I think it was gabapentin for that patient. It was, I think, a few months ago. And then she was eventually followed up in the pelvic pain clinic. But yes, I mean, it's the means to an end. And if you know you've got like a roadblock there, and the best way to manage it is just liaise with the pain team with as much information as possible.
I think the more specialized pain management should be done by the pain team, because it's not just choosing a medicine, it's just assessing the pain more deeply and see what the roots of the pain are and the nature of the pain, and then decide which modality can be used. As endometriosis specialists, we can, I think we can do the standard triad of paracetamol, codeine, maybe some opiates, and the non-steroidal anti-inflammatory. Beyond this, I think it's not just giving this or that. There's more specialized assessment of the pain that needs to be done, because pain modulators are different and they use in different situations. Correct me if I'm wrong, Katrina.
Yes. Yeah. They work in different ways, and it's not unusual for our patients to be on a selection of analgesics, but we just, it's all too easy for analgesics to be kept on added and added and added, and sometimes when we've had patients through from primary care, they're on a whole host of different things and they don't know what's doing what. And they become quite tolerant to many. So we try to tidy up the regime and look at, what does each one do for you? Do you think it's still working? And if they don't, then we often slowly, scale down for them to test out, is this still helping? Yes or no? There's no easy way around that, but they test out and just at least just try and think of which analgesia are doing for them, rather than just keep on adding. And we're, as Madden's talk has said, we're careful not to introduce opioids, to take them down that route, just because of long-term side effects and addiction, and is not supported by NICE. So we are using a lot, and if hopefully you can run the remainder of Madden's talk for you, because I think you'll be going into the role of the tricyclic antidepressants, especially duloxetine we're using more, and the gabapentinoids. So they do have a place, sat alongside which we would very much push is a multimodal approach. So very much bring in the psychology side of things, very much bring in self-care, support out there. And that's why when they're in clinic we ask, what, and you can yourselves, what support have they got around them to help them every day? Have they got washed, dressed, breakfast, medications? Let's go for a walk. And I would love to send a kind of buddy to every lady to, around self-care to keep them going, because this is exhausting for them.